And pleased to have Dr. Pramod Kumar, the Vice President, along with Dr. Prasenjit Ghosh, the Honorary Treasurer, here with us. And we don't have our dynamic Honorary Secretary, Dr. Ruksheda, today with us. But we have got a CME committee who organizes this CME series. Dr. G. Prasad Rao, unfortunately, who's not present with us today. He's the chair, but we do have Dr. Abdul Majid, who's the joint secretary, and myself as the convener. This series has been doing different programs, and different topics are being covered, which have been widely appreciated. And today we have got a very important topic with us. And we have got an excellent speaker along with prominent chairpersons. For the further continuation of the program, I would like to request our Vice President, Dr. Pramod Kumar, to give his welcome remarks and also introduce the chairs. I hand over to Dr. Pramod, please.
Thank you, Dr. Nitin, and welcome each one of you for this Friday CME. This is an important CME, and we have got an excellent speaker. And more than that, we have got excellent chairpersons with us. So both the chairpersons are not only as academician, they are very, very good friend of mine as well. So Dr. Prasenjit and Dr. Jayanta Das. Dr. Jayanta Das, if you know, is a very senior psychiatrist and maybe the senior most psychiatry in the state of Assam. And not only is a great clinician, he's a good academician, and beyond psychiatry, he is a very, very popular person among the people of state of Assam as an actor, director, and producer, and is very closely associated with all the psychosocial dimensions of psychiatry. He has held many positions as a president of the IABP state branch, and then he was a National Advisory Board member of IABP. Then he was associated with IPS in various committees and subcommittees. So if we start going into his CV, so this whole 1 hour would go only in reading about his CV as well. So welcome, Dr. Jayanta Das.
Thank you.
Please,
Thank you.
Okay, and please, this is my briefest CV about you. And
come on.
Okay, Dr. Prasenjit Ghosh. He's a young dynamic psychiatrist, and he's more of a proper academician. He's associate professor, and he has been associated with IABP and then Indian Association of Biological Psychiatry. Then he is the honorary editor, treasurer. He has been having many positions in all the best organizations in the country. And I welcome Dr. Prasenjit for this Friday CME. And
thank you, sir.
I think again I'm saying that he has been having so many awards and associations with so many associations. This is the briefest I could talk about him, and then I go on to the part of the CME. We have got an excellent speaker over here, and who would be introduced by the chairpersons. And then the topic would flow. This particular topic is such a carefully chosen topic and very pertinent to each one of us who is into the clinical practice. Over to chairpersons.
Well, Prasenjit, should I speak first?
Yes, sure, definitely.
So thank you, organizers of this particular CME, and Dr. Nitin, and especially Dr. Pramod, my very dear friend, brother. Thank you for introducing me with all those nice words. And I'm really very happy that I'm sharing with you of this platform after a very, very long time. Well, let me express one thing that since yesterday evening, I'm slightly unwell. Let me underline, I'm slightly unwell. I don't, usually declare that I'm not feeling well, but I have started taking an antibiotic since this morning. But so most of the responsibility I'd like to hand over to Prasenjit, my dear brother. So I'm very happy, and I think this kind of a webinar and this kind of a seminar should continue, which will uplift and enrich our knowledge. So for our psychiatry is concerned. Today, we have a very eminent speaker from my own state. I'm very proud of him, Dr. Dhrubajyoti Bhuya. He's an eminent speaker, he's an academician, a nice gentleman. So, and his brother, he's like my brother to me. So I'm happy that I've got the opportunity to chair his session, and especially the focus will be from our state. And so without making any delay, I would like to hand over or pass the mic to Prasenjit to please introduce today's speaker and the topic. And then, of course, I think we should proceed with the proceedings of deliberations of Dr. Dhrubajyoti Bhuya. Only thing I would apologize if I am not available in between. So hope you'll understand all and bear with my absence for some time. So over to Prasenjit, please.
Thank you, Dada. Thanks a lot to my elder brother, Dr. Pramod Kumar, for his kind words. Dr. Dhrubajyoti Bhuya is a very eminent clinician, academician, as well as researcher. At present, he is working as an associate professor at Assam Medical College, Dibrugarh. He is a life fellow member of various professional bodies like IPS, IABP, Indian Association of Social Psychiatry, and many more. He has received the R.B. Davis Oration of East Zone. He has also got the Best Paper Award in the SAN PGCME East Zone branch in Puri. He has also received prestigious Marfatia Award of Indian Association for Child and Adolescent Mental Health in 2015. He is also in various guidelines committees, and he is one of the expert reviewer of opioid substitution therapy distance learning program initiated by National Drug Dependence Treatment Center, AIMS, Delhi. If I go on reading, it will take long time, but I will cut it short. He has done some real groundwork on the genetics of cognitive impairment in schizophrenia. And thanks to Dr. Dhruva for accepting our proposal to be the speaker. And over to Dr. Dhrubajyoti Bhuya.
Thank you, respected chairpersons. Yeah. Am I audible and visible? Is it my slides are visible, I believe?
Slides are not yet visible. You are visible and audible.
Slides are not yet visible?
Not yet.
Just a minute. Let me stop sharing and we'll again. Is it visible now?
Yes, slides are visible.
Yeah. Respected chairpersons, then respected Pramod Kumar sir, Nitin Gupta, and all the office bearers of Indian Association of Biological Psychiatry. I am grateful to you for giving me this opportunity to talk few lines about cognitive impairment in schizophrenia. And what I have proposed in this presentation is that a brief introduction of different kinds of cognitive impairment which is seen in schizophrenia, and then to some extent the etiological basis, especially a few of the genetics that studies that we have undertaken. Will be presenting at least one because others are not yet completed now, but still I'll try to focus on some of the glimpses of those studies that we have undertaken. And lastly, how to assess and where do we stand as regards to its management and cognitive impairment. If we talk about cognitive impairment, then it is needless to say that we will have to start with imidacloprid. I am not going to talk about the concept of dementia precox, but I would like to quote a patient with schizophrenia, which was there in Kraplin's famous book, where he has spoken that my whole mental power has disappeared. I have sunk intellectually below the level of a beast. So, cognitive impairment is not a new concept. It is as old as schizophrenia is. And marked cognitive impairment is, in fact, a norm and often predates the illness. So, earlier people used to say, which comes first? Is it the cognitive impairment or schizophrenia leading to the cognitive impairment for which the concept of dementia precox was there? But it is needless to say that it is the cognitive impairment which occurs early. Someone has stated the seed is sown even during the prenatal phase, and this grows from childhood till the adulthood. And if we look into, then some of the cognitive impairments like non-verbal and verbal ones, impairments can be noticed as early as at the age of 8 years. And arithmetic abilities can be, defective arithmetic abilities can even be detected at the age of 11 years. So it is much before the onset of schizophrenia. The cognitive impairment in schizophrenia has gained lots of popularity, as you can see from this slide, that in PubMed itself, from the year 2010 to 20, there have been exponential increase in the percentage of articles which have focused on various aspects of cognitive impairment in schizophrenia. And lots of researches and meta-analysis are going on, and which has been summarized in this slide. If I have to say about, then if you look into the prevalence of the cognitive impairment, it is as high as 75% of the people suffering from schizophrenia, and all the domains of cognitive functions are affected, particularly memory, attention, motor skills, executive functions, and intelligence. And as it has already been stated that cognitive impairment often predates the illness onset, and cognitive impairment is related to the social and functional outcome. And though people have been claiming about the newer antipsychotics, even the evidence is mixed regarding the efficacy of the newer atypical antipsychotics in improving the cognitive functions in schizophrenia. And though many people have talked about cognitive rehabilitation as one of the promising modality for dealing with this cognitive impairment, but still the evidence is not that robust. The cognitive ability, some amount of decline of cognitive ability can be seen even from the childhood. And if you compare it with the normal healthy adult, it is much below that normal healthy adults. And if we look into the neurodevelopmental and neurodegenerative models of schizophrenia, then these factors also contribute to the development of the cognitive impairment in schizophrenia. Now let's come down to the cognitive domains. Now, if I have to talk about the cognitive domains, the first domain that we'll be talking about is the visual processing. This visual processing can be oversimplified with gain control and integration. In gain control, it is actually the optimization of the response level, and there is perception of contrast and the motion. And this gain control has got two components. One is dynamic signaling, and second is the isolated registering. So this process is very important. Once this gain control is there, the next stage is the integration, where the grouping of neuronal responses and neuronal co-activation occurs. As a result, there is processing beyond isolated registration. In schizophrenia, this visual processing is defective. if I look into the gain control, it is basically the functions of lateral geniculate body and the visual cortex, whereas integration is the function of secondary visual cortex and other higher cortical areas. So in schizophrenia, there is decreased contrast sensitivity and there is motion processing deficit. Now, next dimension, if I have to look into, then it is the attention. Again, if we look into the attention, then there are two dimensions. One is control of selection, other is implementation of the selection. In control of selection, it is basically the processing of selecting the inputs. And in the other, where is the implementation of the selection, there is differential processing of what has been selected and unselected inputs, because there are lots of redundant informations also. It is the prefrontal cortex and the parietal cortex which is actively involved in the process of selecting the inputs. So while in case of implementation of the selected or unselected inputs, it is the different processing areas such as visual cortex. Then there is a phenomenon called rule selection, where it will govern the ongoing processes, which inputs are to be given attention and which are to be left aside. And in schizophrenia, there is problem with prefrontal cortex. So some amount of problem with the attention has always been reported. Another function of prefrontal cortex is the working memory, which involves three factors. One is keeping the information online, and second is goal maintenance as well as inference control, because there are lots of inferences from internal world as well as the external world. So the person has to deal with all these. And if we look into, then this inference control is basically the function of left ventrolateral prefrontal cortex, while the goal maintenance has been done with dorsolateral prefrontal cortex, and different neurotransmitters have been implicated for this goal maintenance, starting from dopamine, glutamate, and norepinephrine. And impaired working memory, it is needless to say about the cognitive impairment in schizophrenia. Now, when it comes to the matter of long-term memory, there are different areas of the brain which are implicated. One is perirhinal cortex. It is important for near normal performances, while hippocampus is responsible for recollection of information. And our prefrontal cortex, apart from attribution of the salience, it is important for episodic encoding and retrieval, while ventrolateral prefrontal cortex is responsible for item-specific processing, and rational encoding is done by dorsolateral prefrontal cortex. In schizophrenia, this perirhinal cortex and prefrontal cortex are mostly involved. Therefore, there is impaired relational memory measures, whereas familiarity-based item recognition is usually spared. Ranganathan has found that encoding and retrieval processes are more affected than long-term storage in case of schizophrenia. And Raglan has said that reinforcement learning seems to be affected, but other studies have not reciprocated this finding. Then executive control. In executive control, there are two things. One is rule generation and selection. This rule generation and selection requires activation tasks related to certain cues based on certain rules, while the dynamic adjustment in the control requires detection of the conflicts or the errors in processing. Prefrontal cortex is necessary for this rule generation and dynamic adjustment is the function of anterior cingulate gyrus. And sensory gating mechanism is important in rule generation and selection. And therefore, in schizophrenia, since there is a sensory gating deficit, so there occurs error in high conflict situations. Now, social cognition, though people have talked many things about social cognition, even Osner has given his model of social emotion processing, which includes acquisition of social affective values, recognition of and response to the social affective stimuli, then embodied stimulate or low-level mental state inferences, high-level mental state inferences, and context-sensitive regulations. But the problem is that this model is very poorly understood in case of the normal individuals, though people have started working on this social cognitive impairment in schizophrenia. There are different tools to assess the cognitive impairment. The one is metrics. This was NIMH initiative where the measurement of and treatment research to improve cognition in schizophrenia. Then second is CNTRIC, which is cognitive neuroscience treatment research to improve cognition in schizophrenia. So different dimensions are tapped in these two initiatives. And in matrices, schizophrenia cognition rating scale has been used, and we have used this scale to examine the level of cognitive impairment in schizophrenia, where we have found that at least these are much less as compared to the control in all the dimensions of this scale, starting from memory, learning, attention, working memory, problem solving, processing and motor speed, social cognition, language. And even the overall score, if you look into, then there is definitely a significant difference in cases as well as the control. Now coming to the etiology, when we'll be talking about etiology, we'll be talking a little bit about genetics. But the problem with genetics is that there are as many as 4 different theories related to genetics and its involvement in cognitive impairment. The first one, it views the cognitive impairment just as a confounder. According to this gene and the brain environment insult will lead to the brain abnormality that will lead to psychosis, and this same brain abnormality will lead to abnormal cognitive functions. Whereas if you look into the second model, where gene has been implicated as the independent cause, if you can see it, the gene, brain environment insult, and abnormal cognitive functions, they will act as a causative agent for the psychosis. Whereas in the third model, causes of psychosis with abnormal cognitive function lying on the causal pathway only. It is the gene and the brain environmental insult which will lead to the abnormal cognitive functioning that will in turn lead to the psychosis. Whereas the fourth and the last model, it will say that the cognitive function lie on the causal pathway, but other direct pathways also are quite important. Now, based on these, we'll proceed with our genetics. But this is a humble submission that genetics in this part is still in infancy. And if we look into, then heritability of schizophrenia is as high as 80%, and it is the environmental factors which has decreased it to below 40%. And it is a polygenic inheritance, and most specific alleles contribute only a minimal degree of risk. If you look into the median odds ratio, it is just 1.05, and therefore it is very unlikely to have major pathophysiological relevance in isolation. And both twin and genome-wide association studies have shown a very strong negative genetic correlation between liability of schizophrenia and cognitive abilities, indicating that they always share a common genetic factors. Different genes have been studied, neuroregulin gene, G72, and then DISC1, this binding protein gene, catechol O-methyltransferase gene, then gamma aminobutyric acid receptor A gene. So what I will be talking about our work on this binding, or this is DT-NBP1 gene and catechol O-methyltransferase gene and GABA receptor gene. So there are many genes. These genes have been incorporated. If we look into this binding one, it is associated with different kinds of protein expressions which are required for molecular and neuronal morphologies, neurotransmitter release, even gene transcription and neuronal development. So this gene is very important, and Elizabeth has said that this DTNBP1 gene, it encodes this binding one, and he has identified two important alleles. One is P1635 and P1655. According to him, this P1635 does not have got much of the influence on the cognitive impairment in schizophrenia, but 1655 has got definite role in causation of cognitive impairment in schizophrenia, especially in Western countries. So the same genes were studied, same alleles were studied in our part, because this DTBPN gene, this is pivotal in regulating glutaminergic system, and it is needless to say that this glutaminergic system plays an important role in the cognitive functions or dysfunctions. But our finding, we couldn't find any difference at all in case of cases as well as controls. And this finding is not, because this study is, to best of our knowledge, is first of its kind in India. If we look into other studies which have incorporated some of the people from Southeast Asia, they also couldn't find any involvement of this SNP1655. So at least we can conclude that this SNP in this part of the country does not have got any role in the cognitive dysfunction in schizophrenia. Then next important gene is COMT, because it has got a wide range of action on different kinds of neurotransmitter system. So this year we have started investigating into the roles of COMT gene, and specifically we have taken this SNP, well, 158 met or repeat number sequence of 4681. But only the gene extraction has been completed in case of schizophrenia, but it is not yet completed in case of controls. So the results are yet to be there, which are. Then the next gene, again, which we have taken up is the GABA receptor A6 gene. Again, repeat number sequence is 3219151. Again, this is not yet completed, but probably it is indicative that yes, we are getting some of these genes are being isolated from the cases of schizophrenia, but now again the control recruitment is not complete, so we'll have to wait for some time to get these results. Now, what these genetic studies have shown is that negative genetic correlation is minimum or absent between the polygenic risks for bipolar disorder and cognitive functions. Why I am specifically bringing this? Because there are certain genetic overlaps between schizophrenia and bipolar disorder. But if we look into the cognitive functions, then this overlap is not there. Therefore, what has been proposed is that polygenic risk score for bipolar is associated with poor cognition in childhood, primarily as a result of single nucleotide polymorphism with schizophrenia. But bipolar order specific risk alleles are associated with better cognitive performance. So in other way, we can say that this cognitive impairment can be the phenotype of schizophrenia. Now coming to the neurotransmitters, again, for any kind of psychosis, dopamine is to be blamed for, but the relation is not that simple like what Matt Heisey would have said long back, that increased dopamine will lead to schizophrenia and all other things. It is the cortical dopamine signal which plays a role in normal attention, working memory, and executive function. So impaired dopamine function is therefore expected to be the cause of the cognitive impairment. Rather, it is the cortical hypodopaminergia which will lead to the striatal hyperdopaminergia. And there is lack of dopamine antagonist on cognitive symptoms. So there is no effect on the dopamine antagonist on the cognitive symptoms or the cognitive impairment, which will reflect that there is the dysregulated striatal signal. That is not only the thing, but we need to block the aberrant signals as well as restoration of the signal noise ratio of the adaptive signals. Experimental lesions in the prefrontal dopamine function leads to the impairment in the dopamine signaling, which will lead to the impairment in the working memory as well as the executive functioning. It is only a fraction of cortical pyramidal neurons will express dopamine receptors. And in pyramidal cells and interneurons, this dopamine's presynaptic effect is predominantly inhibitory, while in postsynaptic pathway, it is excitatory. The net effect of this excitation and inhibition balance is very important in maintenance of the cognitive functions. Then acetylcholine. Again, lots of focus has been given on the acetylcholine, and these acetylcholine innervations are split into the two primary networks. If I look into our anatomy or the physiology days, then it is the pedunculopontine cholinergic complex, which will be projecting to the midbrain, and the second is the forebrain complex, which will again project to the cortex. The effect of acetylcholine is mediated by nicotinic receptors as well as muscarinic receptors, and acetylcholine nicotinic receptor, it is important in improvement of sensory getting mechanisms. Now, the problem is that the varenicline or acetylcholine studies inhibitors have got a very disappointing results. So what we are focusing now is on the aberrant functioning of the muscarinic receptors, and therefore people have started focusing on different kinds of remedies like muscarinic antagonists for cognitive deficits as well as the positive symptoms of schizophrenia. Again, if I look into the muscarinic receptors, there are predominantly excitatory and inhibitory. The excitatory ones are M1, M3, and M5. Inhibitories are M2 and M4. And in schizophrenia, there is reduction of M1 and M4 receptors in hippocampus and cortex. And this M1 receptor is hypothesized to play an important role in learning and memory. Now, nicotinic receptors, it will affect the GABAergic and glutaminergic signal. And again, thereby what we were talking about, excitatory and inhibitory balance will be affected. These nicotinic receptors are abundant in interneurons, particularly those interneurons which will release VIP. And this VIP will inhibit other interneurons, and the net effect of this nicotine stimulation on this excitatory or inhibitory balance is therefore to increase the pyramidal cell firing, and that might lead to beneficial effect provided there is reduced pyramidal signaling. But it is unlikely to be helpful if there is a state of cortical disinhibition, which usually occurs in schizophrenia. These M1 receptors, we have said that M1 receptors play a very important role in learning and memory. And this is strongly expressed in pyramidal cells, which suggests that net effect of this M1 agonism can lead to cortical excitability. The overall effect of modulating this activity is likely to depend on degree of the endogenous tone. At typical level, this may already be saturated, such that effects are primarily inhibited via increased activation of interneurons, or a direct effect on pyramidal cells via other pathways. So, if I look into the excitatory and inhibitory balance of what I was talking about between and compare it with the healthy control and the schizophrenia, then you can see that there are aberrant neuronal oscillations and there is defective network functions, and that will ultimately hamper this excitatory and inhibitory balance, and that will ultimately lead to the cognitive impairment in schizophrenia. Of course, glutamate is important, and its renewed interest is because of the chronic use of ketamine. It is important for encoding, but it is not important for retention of information. It is important for context, but not with the target processing. And it is not important. It is not seen to be associated with switching during the cognitive control. And we need to say about the different NMDA receptors and the excitotoxicity which are implicated in possession of cognitive impairment. And this GRIN gene is implicated in the pathophysiology of schizophrenia, and its mutation, particularly 2A gene, increases the risk of schizophrenia, but not for the other developmental disorders. Now, it is the calcium flow through the synaptic NMDA receptor that exerts the long-term potentiation and the cell survival. And this calcium entry through extrasynaptic NMDA receptor will lead to the mitochondrial dysfunction, loss of integrity in the neuronal structure, neurotoxicity, and cell death, which can lead to the cognitive impairment. So, if I look into, then it is again the dysfunction between the dopamine and the glutaminergic system, basically that will play a very crucial role in development of the cognitive impairment in schizophrenia. Another important finding was seen with cannabis. Acute cannabis was seen to be associated with some improvement of cognition in schizophrenia. And this is particularly quite interesting, and people have said that it is the cannabidiol which has probably contributed to the improvement in the cognitive functions. But those who are dependent on cannabis, this effect is not seen. Rather, it has led to the further deterioration of the cognitive impairment, and tetrahydrocannabinol is responsible for that. Another explanation which has been given for this finding is that individuals who develop schizophrenia in the context of cannabis use have relatively less genetic predisposition, and therefore they have got a less impairment in the cognitive functions. And there are sensory processing dysfunction, and these are like we have talked about the auditory system and the visual system, which we have talked about. And in schizophrenia, it is the peripheral aspect of the auditory system is usually unaffected, but it is the central part which is basically affected, and there is deficit in the simple tone mismatch ability. And there is deficit in the early auditory processing, and second group has been seen as there is the intact early auditory processing and lower functional connectivity between medial geniculate nucleus and the auditory cortex. And this will lead to the lower estimation of the premorbid IQ as well as poor cognitive performance. If I look into the visual system, it is the magnocellular pathway, paraventricular pathway, and retrotactile pathway. These three pathways are important. These magnocellular and parvocellular pathway, they will be connected to the lateral geniculate nucleus, which will relate to the cortex, and while the retinotactile pathway, it will have its projection towards the superior colliculus and pulvinar nucleus. Then the signal will go to the cortex for interpretation. Now what happens? This magnocellular pathway, it is important for rapid detection of the low contrast, low spatial frequency motion stimulation involving attentional capture and framing of the visual scene. While parvocellular pathway is important for slower but more graded analysis of the fine spatial details and the project primarily to the ventral visual regions. While reticulotactile pathway, it is involved in visual development, and it conveys trait-related activity rapidly to the visual cortex as well as amygdala. So what happens in schizophrenia is that there is basically a deficit in detection of the lower contrast and low spatial frequency as well as the motion stimulus. And this has been linked to the impairment with the NMDA receptor dependent not linear gain function of the magnocellular pathway. And this has been implicated in the causation of the cognitive impairment. So the net result is that impaired contextual processing will be there. There will be poor cognitive control, object recognition, and face emotion recognition will be affected. There will be poor contour integration, and visual and oculomotor aspect of the reading will also be affected. So, having talked about different dimensions of the cognitive impairment in schizophrenia, the people are keen to develop some of the strategies to deal with this cognitive impairment, because this is just not a mere association, this is the part of schizophrenia. And the antipsychotics have got a very conflicting kind of results. Whatever has been shown from the different results, that the first generation antipsychotics have got the minimal effect, and the second generations are also not very encouraging. The results are not very encouraging. Mean effect is 0.3 to 0.43 only. People have talked about cognitive remediation techniques, but again, the results are mixed. So some of the studies have shown some kind of promising results with cognitive remediation. So still, we need to have a fair bit of idea regarding the pathophysiology of this cognitive impairment, then only effective strategies to deal with these cognitive impairments can be proposed. Hope I have not bored you too much. Thank you so much.
Thank you, Dr. Dhruva Bhuiya, for your nice presentation. So, in the initial part, actually, you have nicely dealt with your work that you have done in Assam Medical College, Dibrugarh, and then some overall view we have given. Cognitive impairment in schizophrenia is one of the core features, as you have told. It is not a incidental finding or a mere association. And importantly, this cognitive impairment appears much before the appearance of the symptoms of schizophrenia. And most of the researchers have found that the cognitive impairment in schizophrenia is 1.5 to 2 standard deviation below the normal controls. Whereas in bipolar mood disorder, the cognitive impairment is around 1 standard deviation in comparison to the healthy controls. While you have said correctly that most of the antipsychotics have no effect or minimum effect on cognitive improvement, recently some people have claimed that cariprazine has got some effect on cognitive impairment. And also non-pharmacologically, if we say that some steps can be taken like cessation of smoking, regular exercise, controlling body weight, and healthy diet, and obviously cognitive remediation, computer-assisted cognitive remediation, and others that people are trying all over the globe. And the aspects of cognitive impairment, the factor analysis have found there are basically 7 domains that are mainly affected in schizophrenia. Main important is the speed of processing, working memory, attention, verbal learning, visual learning, reasoning, and social cognition. The most important, what I think, are the two. One is social cognition and one is speed of processing, which inversely or negatively affect the overall outcome in schizophrenia. For example, getting a job or living a life independent. So thank you once again. And with these few words, I think there are no questions in the chat box. So over to the organizer, Dr. Nitin Gupta sir, for further proceeding. Over to Dr. Nitin Gupta sir for further proceedings.
Muted. I'm saying it's thank you, Dr. Prasanjit. But I think it's very surprising that no questions have been asked, probably related to the complexity of the topic, as outlined by our speaker and also by yourself. But this both theoretically and clinically, it's not an easy area to deal with. And as that has been highlighted by Dr. Dhruva in his presentation, I think I can't add more than that. And it's unfortunate we don't have any questions. But my job here is to actually thank Dr. Dhruva for his excellent presentation. Dr. Prasanjit Ghosh and Dr. Jayanta, though he was unwell, he still managed to join as a chairperson for chairing the session. To Dr. Our President, Dr. UC Garg, Vice President, Dr. Sunil Mittal, and Dr. Pramod, Dr. Ruksheda, our Secretary, again, Dr. Prasanjit as the Treasurer, and Dr. Aleem Siddiqui as the Honorary Editor, our office bearers in all, who have been the driving force behind this series. And not once again to mention that it's Dr. G. Prasad Rao who has initiated this overall concept along with Dr. Majid. I think such topics are important to discuss, that although they may not have generated a detailed discussion today, but at least they would stimulate some thinking for us to go back and try to address these issues. because this is something which patients do complain about, they do suffer with. And as clinicians, we do have to deal with this vexing issue. And I would like to thank all for their active involvement and participation, whoever was available today. And people can watch this live on the IABP YouTube channel. And also it's available on the journal link also, and it will also be available on the IABP newsletter link. So with these closing remarks, I wish you all a good night and thank you for joining us today till the next session, which will be on the first Friday of September. Thank you very much. Thank you.
Thank you to you also, Nitin sir, for moderating today's event. And good night.
Good night. Thank you very much.
Good night. Prasenjit, good
Good
night.
night.
Nitin sir,
Good
good
night.
night.
Good night.
Probably I have met you for the first time.
Yeah.
Okay, we'll be
Thank you.
meeting more frequently.
Bye.
Yeah.